BRLSI Spotlight feature in which I'm going to be talking to Professor Ed Feil, who's Professor of Microbial Evolution at the University of Bath. Perhaps you've already watched our previous conversation about the nature and origin of the SARS-CoV-2 virus, the organism that's causing the current pandemic infection called Covid-19. If you haven't, well, you can always visit the virtual BRLSI YouTube channel and find it there, or the BRLSI website. But actually, you don't need to do that first. The spotlight session that we're going to do now doesn't make any assumptions about what you know already, so just go ahead and listen. This time, I'm going to be talking to Ed about how and why the virus is spreading so fast and so far. Good morning, Ed. Nice to see you.
Yep, see you too.
We've heard a lot in news bulletins over the past week or so about the very fast spread of the coronavirus, first in China and then in other Asian countries and now the rest of the world, Europe, the USA, and that's why the World Health Organization has now described COVID-19 as a pandemic disease. So that really focuses our attention on this idea of infectivity, and that's what we're going to be talking about today. What can you say in general about how disease-causing organisms spread between people?
Okay, so in order to cause a disease, a pathogen, a microbe, a virus or bacteria or fungus will need to gain entry into the body somehow, normally, and that can either be through a natural opening, like the mouth or the nose or the eyes or the urinogenital tract, for example, or it could be through insect bites or through wounds. So the various ways in which these pathogens can spread from person to person include ingestion of contaminated food. So E. coli and Salmonella are classic food-borne pathogens. You have waterborne pathogens also are ingested, like cholera, for example, is spread through dirty water. Some diseases are vectored, which means they have an intermediate host, usually an invertebrate host, like a flea famously spread the plague, the Black Death. Mosquitoes carry malaria and a number of other viral diseases, and of course they inject the parasite directly into the bloodstream through their bites. But when it comes to respiratory pathogens like coronavirus and also influenza, what we're really talking about is predominantly in terms of human to human transmission is droplet infection. So droplet infection refers to the process whereby coughing or sneezing or simply exhaling releases tiny droplets of moisture from your airways, from your lungs, which will contain virus particles, and these can travel a short distance before falling to the ground, and where the virus will quickly die, but they can travel for upwards of a meter or maybe possibly 2 meters, and this is why we have to maintain a distance from one person to another. Now, it is important to make the distinction between droplet infection of this kind and true airborne diseases, which form what are called aerosols. So an aerosol refers to the fact that the much smaller particles, much smaller droplets, or just the particles on the virus particles on their own, can remain suspended in the air, not just for minutes but for hours, and that still be active. So a disease like measles is spread like this, so it's very, very contagious, and foot and mouth disease in animals is another example. So these proper airborne diseases are the most contagious ones, the most easily spread, and that's not what we're dealing with coronavirus. But of course, the other route by which coronavirus can spread is through surfaces, as we all know about. So when if our hands are contaminated or if the droplets fall on a surface, then the virus will remain active on that surface for some time and potentially can be picked up by another individual.
Yeah. So this isn't an accident, is it? When we talk about these pathogens, they're actually evolved to spread in these ways. And so a disease isn't going to be spread by some other means because it's actually highly specialized to be spread in exactly that way.
No, that's absolutely right. Of course, the whole raison d'etre, the whole function and the existence of a pathogen like a virus depends on its ability to get from one host to another. So it's never going to evolve if it doesn't have a very efficient way of exploiting the hosts that it's got around it.
Yeah, and just to be quite clear about this, to make sure that everybody is quite sure about it, you aren't going to get this coronavirus from being bitten by a mosquito, are you?
You're not going to get this coronavirus from being bitten by a mosquito, no. And it's the other sources that people have talked about are the fecal oral route, and that's also very unlikely. There's a formal possibility is the virus is detected in feces, but the probability of actually it being active and actually being an important mechanism of transmission is very, very low. So we're really thinking about droplet infection and surfaces. Pets are the other things that people have been talking about. You could really see pets as another surface, I think, is probably the best way to. So if someone has is carrying the virus and is petting a dog, then there's a chance that virus will be on the fur and remain active long enough to be picked up by someone else who then subsequently pets the dog.
Although there was an indication earlier this week that cats might possibly.
I did see that.
That's right.
Yeah. I don't know. I mean, it's early
jury's out on that.
It seems that cats are more risk than dogs. There was also a case of a Pomeranian who had a weak signs of dog that had a weak signs of infection, but it's really too early to say what the pets is.
Okay, Ed, let's just take a slight sideways digression in our conversation here. You just mentioned the possibility that virus particles might be excreted, and there's actually a very interesting possibility that you might actually be able to track the progress of the epidemic by the number of virus particles that appear in sewage and wastewater. Have you come across this?
Yeah, that's a really, really neat idea. So it's in the case of coronavirus specifically, this approach has been pioneered by a Dutch group, but there is a group also at the University of Bath who have been working in the Department of Chemistry, who have been working on this idea of wastewater epidemiology for some time. And it's really clever. So essentially, in terms of coronavirus, what you can do is use more or less the same approach that is used in the tests, the PCR tests, for detecting it within a single individual. You can use that on bulk sewage, so you can get some idea of the prevalence within a particular community of the disease, which when you imagine, in a few weeks' time, hopefully when we've got over this initial wave of infections and we're in a place where we're more set up to roll out community-based testing, this will really be a very useful supplement to those sort of methods, because it's a very low resource, quick approach for getting some sort of handle on the overall burden within a community, a town or a city.
Well, okay, that was an interesting little digression there.
Sure.
But what we're really doing today is talking about epidemiology, which, the fact that this is branch of science has a special name tells you that there's quite a lot to get through. Well, reading the papers and looking at the internet over the past couple of weeks, we've heard really an awful lot about mathematical models of the spread of this virus, SARS-CoV-2. And what about these models? How do they work, and are they useful?
Are they useful? Well, I'll refer to the oft quoted citation from a statistician called George Box, who said that all models are wrong, but some are useful. And I think that that's really a very good starting point, because they do make simplifying assumptions. They don't reflect the complexities of real life, but at the same time, you can use them to make general predictions about how an epidemic is going to unfold, and importantly, about how particular interventions may alter the course of that epidemic. So you could ask, what effect will school closures have, or what effect will contact tracing have, or any of these other interventions that we'll talk about later. So they do provide a handle on what the best sort of management strategies might be. It's worth bearing in mind that most epidemiological models will assume onward community transmission, so onward transmission from one human to another. And there are some diseases where this really isn't relevant. So if we take the case of a disease like inhalation anthrax, for example, which is it's what's called sporadic. So every now and then an unfortunate person may have a case of inhalation anthrax, which is very serious for that person, but it's very unlikely that it will go on to spread to other people. So these models are really sort of most useful in these sort of circumstances we find ourselves in now, where you've got chains of transmission, and you can say something about the likelihood of transmission and how quickly transmission occurs.
Yeah, okay. So this is the key idea, isn't it, behind the model, this idea of the number of cases that each individual case then spawns.
Yeah, so this is the R0 statistic, which is
R0.
Yeah,
that's a bit impenetrable, Ed. Is there a sequence of words that
yeah, so R0 is actually a very simple concept. So it's simply the number of people infected that we can expect from one individual who's become infected. So if you or I get infected, then it's the average number of other people that we might expect to go on and infect. So the estimate for this new coronavirus is hovering around 2.5. So in other words, if we were to get infected tomorrow, then before our infection resolved itself one way or the other, we might on average have expected to infect a further 2.5 people. So of course, if that number is over 1, then we're in trouble, because the cases will go on increasing. If that number's below 1, then the epidemic won't be able to sustain itself. It'll be self-limiting and just fizzle out on its own. So all the measures that are in place at the moment are really designed around pushing that number down to as close to 0 as possible at the moment. So there is some assumptions in our R0 is kind of in a sense, the idealized reproduction number, it's called. So the basic. So in actual fact, what we're really talking about is R, which is what you actually see, the effective reproduction number. So this takes into account the intervention measures that we put in place, but also critically the amount of susceptibility within the population. So some individuals will be much more prone to getting infected than others. So so R is the number that we actually observe, taking all those things into account.
Yeah, and it is quite likely that there'll be genetic differences between individual people in their susceptibility, isn't it?
Yeah, there probably is genetic differences. We don't really understand what those are at the moment. There certainly seems to be a gender difference.
Yeah.
So males seem to get much more severe symptoms and are more likely to die than females. And one possibility to explain that is that females are what's called the homogametic sex, so they have two copies of the X chromosome, and some key immune genes are actually coded on these X chromosomes, and because females have got two copies of them, that somehow makes their immune system a little bit stronger than males' immune systems. That's one explanation. But there are also big differences in symptoms. We know about age. We know that older people are more prone to serious symptoms than younger people, and that's probably a function of immune efficiency as well, which is known to go downhill quite rapidly after the age of about 50.
I gather you had your 50th birthday not long ago.
Yeah, it's all downhill from there. So the number of white blood cells circulating goes down, and the overall sort of efficiency of the immune response decreases in everyone, regardless of, obviously it's good to stay fit and healthy, but that is a process which is basically impossible to arrest completely. So
this R naught number, you said that we have an estimate of what this number is, and you were very clear there that when we talk about R naught, we're talking about a disease spreading into a population that doesn't have any immunity to it, because that really complicates it. But in this case, of course, that's exactly what's happening, isn't it? Because there's essentially no immunity to this disease because it's a new disease. But you said that we have this estimate that it's somewhere between 2 and 3. Now, are we quite confident about that? How do we know that?
Yeah, so it seems to be a consensus forming that's about that's the sort of figure we're looking at, and obviously that's made up of lots of other estimates. So to borrow a handy acronym from a very high-profile epidemiologist at London School of Hygiene, Adam Kochanski, who's done a lot of work on this particular outbreak. He uses the acronym DOTS to help explain what this figure of R naught is actually made up of. So DOTS stands for duration, opportunity, transmission probability, and susceptibility. So duration is simply the length of time that a single infection will last in a person. And for this coronavirus, we're looking at probably about 2 to 3 weeks. That's fairly well established. For something like HIV, of course, it may be 20 years. So this really varies according to different diseases. So the opportunity, this is the thing that we can do something about. So this is the amount of contacts, the amount of ways, the chances that a virus might spread from person to person through droplet infection or contaminated surfaces or whatever. So this is the thing that we have some control over and what we're trying to reduce by all this social distancing. The transmission is the transmission probability, which is kind of hard to guess. We can make some guesstimates, but we don't really understand fully what's called the infectious dose, how much virus is needed to actually cause a new infection. And the susceptibility we've already mentioned is really refers to the amount of immunity in the population. So the only safe way to decrease susceptibility, to increase immunity, is through vaccination programs. So we've heard something a little while about how we might expect this thing called herd immunity to develop if we were just to allow enough people in the population to get infected. So which in principle sounds like a great idea, but when you do the maths, that's actually going to result in hundreds of thousands of deaths. So it's not particularly great idea. Vaccination, mass vaccination, will of course have the same effect. And this idea of herd immunity just refers to the point at which the proportion of the population which is immune to the disease is such that the R dips below 1, so that the epidemic is no longer sustainable. If we digress for a moment, think about a different disease, measles, which is, you remember, this is an airborne disease. This is a very small virus, much smaller than coronavirus, very hardy, so it can survive sort of suspended in the air for a long time. So it has an R naught of much higher, 12 to 15, very, very contagious. So this means that the level of the proportion of the population that needs to be immune to get herd immunity in measles is something like 95%. For coronavirus, the estimate's about 60%. So this really is why everybody needs to have their MMR jabs, and why these scandalous reports about MMR have been so damaging, because if you don't hit that very high level of immunity, then you don't get the herd immunity effect, and the epidemic, the outbreaks can take off again.
Yeah. Well, there's certainly been some confusion in the news reports over the extent to which the UK government strategy for managing the coronavirus outbreak was predicated on this idea of herd immunity. And perhaps we needn't go into that in detail here. But the point of this is that it focuses our attention on the fact that the R0 number is actually very important, because it enables us to calculate how many people would need to be immune in the population in order to stop the disease spreading.
Sure.
And there's a bit of a problem too, in that the R0 figure is an average, isn't it? Whereas there are quite a few reports that actually there may be super spreaders of this disease who actually have individually a much higher R0 than other people, and that would make the calculation very much more difficult to do.
Yeah. So this is a common phenomenon we find with many outbreaks, that you have certain individuals that shed a lot of virus and will infect a great many other people. So that I think that was the case in South Korea. There was a patient in that particular church that infected.
And that might be physiological, or it might just be behavioral, mightn't it?
Yeah, it might be both. Yeah. So typhoid Mary, of course, was the classic example of a.
Well, the thing that I find really fascinating about this area that we're talking about is, how one gets the information in the first place. And these cruise ships where people became infected in a closed community, it's like a natural experiment, isn't it?
It's a bit sanguine, a bit macabre to say, but it has a really useful data set. So one of the big unknowns has been, so how many cases are we missing? How many people are asymptomatic or more likely pre-symptomatic, so have the infection but will go on to have symptoms but not yet presenting with symptoms. So in the cruise ship, when everyone was tested, I think the number of purely asymptomatic cases was somewhere around 20%, but then there was an additional say 30-40% that were tested negative but then went on to tested positive but without symptoms, but then went on to develop symptoms. So this is kind of panning out to a degree over larger populations. Of course, the trouble with the cruise ship is that they tended to be old people, so they're not a very representative sample of the overall demographic, and they probably have more severe symptoms than the general population. There's also been studies on repatriation flights from Wuhan where everyone was tested, and then we can get a sort of gauge a figure on the number of asymptomatic and pre-symptomatic cases in the same way, and the figures are roughly similar, actually.
Yeah, well, one has to be, of course, terribly sympathetic with the people who were trapped on these
It's
cruise
dreadful.
ships
Yeah, dreadful.
Held in there for obvious reasons. I don't know if it's comforting for them to know that actually this natural experiment is very useful for the rest of the world.
Sure.
Yeah. Okay, so we've been talking a little bit here about these models of infection. But actually, what we read about in the newspapers every day is the number of supposedly confirmed cases, which I suppose represents the results of testing, and also that the numbers of deaths that are reported. And I wonder if you can just give me your take on what those current figures for the spread of the coronavirus tell us. And, is this useful information, or can numbers like that actually be misleading? What do you think?
So both of those numbers are wrong, in the sense that they don't reflect the actual number of cases and they don't reflect the actual number of deaths. But that doesn't mean they're not useful. We just have to be aware of how wrong they are and try and correct for that. So recent estimates in terms of the number of cases. So as you said, the number of cases is always going to be an underestimate because, as everybody knows, we're testing a tiny proportion of the actual number of cases that are out there, especially in the community where we're not doing any real testing at all at the moment. So all the testing we're doing is in hospitals and a few the healthcare workers. So a reasonable estimate of the number of how to go from the observed number of cases to the actual number of cases is to multiply by around a factor of 20. So we're detecting roughly 5% of the actual cases. So if we're at the moment, as of Saturday, well, it's now Sunday, so as of yesterday, the 4th of April, there were something like about 41,000 cases recorded. So if you multiply that up by a factor of 20, you get about 800,000 actual cases, and I think that's probably where we are, roughly around 1 million actual cases at the moment altogether. The number of deaths also tells us something, but it's also misleading for different reasons. So one reason is that the number of deaths reported for a 24-hour period is just that. It's the number of deaths that have been reported in that period. It isn't the number of deaths that have actually occurred in that 24-hour period. So many of those deaths will have actually occurred earlier on. And what that means is that because of the delay in reporting, we're probably underestimating the actual number of deaths that are happening. Another problem with deaths is that not all the deaths are actually tested post-mortem. So there may be quite a lot of deaths of COVID that aren't actually recognised. So the number of so what's happening in Italy, the region of Bergamo in Lombardy, there's been estimated to be about 2,500 deaths over the last few weeks. But in actual fact, if you compare the total number of deaths from that region for this month, the month of this year, the last month of this year, with the same month last year, it's gone up from about 1,000 to about 5,000. So actually, the excess death is more like 4,000, and a lot of those will be COVID. So that gives us some sort of handle on how much we're underestimating the death rate. So both of these figures are wrong, but we can still gauge overall trends, and in fact it's impossible not to. I know we are both looking at these numbers every day and over-interpreting them, no doubt. But
it's
very difficult. It's very difficult not to, because we're desperately looking for signs that we're reaching that plateau in cases. But really, we're not going to know for sure until we see a trend that's sort of robust over at least sort of 3 or 4 days. So we've got to try and resist that temptation to overinterpret single results for a single day as much as we can. But
yeah. So, why are we doing all of this modeling? I guess that one of the reasons that we do the modeling is that we want to know how fast the numbers will go up.
Sure.
And you said earlier on, well, any value of R0 that's more than 1 is going to lead to the disease spreading. And the inexorable mathematical law is that when you have a process that feeds back on itself in the way that the spread of infection does, the way that the numbers increase is so-called exponentially. And I think a lot of people really have a hard time getting hold of this idea. One way of thinking about it is this idea of doubling time. Would you like to just talk us through that a bit? I mean, what's the doubling time for cases of COVID-19?
So the doubling time simply refers to how many days it takes to so if we have 100 cases today, how many days will it be before we have 200 cases? So how many days will it take for the number of cases to double? For coronavirus, we're probably looking at somewhere around 4 or 5 days.
That's what I make it.
Yeah. So when you actually sit down and think about the numbers, I mean, you can understand that, fairly intuitively on one level.
It's horrific, isn't it?
But when you actually, I mean, it's surprising, even though we kind of understand what that means. When you actually sit down and work out the numbers,
well, yes,
we're so programmed to think in terms of linear increases that it's almost impossible not to be surprised at how quickly you reach these so-called inflection points. Which reached like a week or so ago when we had this lockdown, where suddenly the graph shoots up. And then shoots up more and more and more and more. So it's genuinely frightening, and that's how these models are useful for, say, sort of estimating worst case scenarios. So one of the key models that influence the government and probably pushed them towards this sort of lockdown situation was the model from Imperial College, where they estimated that, other things being equal, if we just left this thing go, then we'd expect a minimum of about 250,000 deaths. And of course, combined with our capacity in the health service, there's obviously going to be serious knock-on effects as well for people who were ill anyway, and all the rest of the damage that would cause. So quite horrific numbers, and that's what really, as I say, that's based on this kind of doubling time idea.
Yeah. So, well, I mean, the way that I do the calculations is that within something like a month, you could easily get to the state where the entire population of the UK would be infected. Now, of course, that's not really going to happen, is it? And that's because you'll run out of people to infect, and of course, also all of this time you'd be building up immunity. We talked about immunity before. So this concept of immunity is very important. We'll talk about this more in another one of these conversations. But for now, what we can say is that people who get infected with a non-lethal infectious disease, they recover because their immune system fights off that disease, and then they don't get it again, or at least they don't get it for a fairly long time. Now, do we actually know that that's the case for COVID-19?
No. Well, but I think it's a safe assumption. It's a reasonable assumption. It's more because that's so so commonly, the typical case. That's what we expect to happen, and we don't have any real reason that won't happen. There's been some reports of people getting the infection twice. Which can happen as rarely in other diseases as well. So it's not something I think to be overly alarmed about. So I think that we're still have no reason to doubt that we will get immunity. How long it lasts for is another question. And of course that also will determine how well the vaccine works when we get the vaccine.
When we get a vaccine.
Yeah, when we get a vaccine.
Yeah.
So hopefully we won't need a vaccine every year. Hopefully it will last a bit longer than that. But we'll just have to see. The coronaviruses are slightly unpredictable in how long immunity lasts for, actually. So we'll just have to see. But it certainly should last. So if we're thinking in terms of sort of concurrent waves of infection over, say, this year, then I think I'm confident that this initial wave will be the worst.
Yes.
For a number of reasons, the build-up of immunity being one of them, and of course the others being that we'll generally be in a better place with having ventilators and beds and staff, and maybe some therapies as well, some drugs that will come along. But yeah, so as time goes on, immunity will build up, and we won't see such horrific surges. So we won't need to have quite such dramatic sort of intervention measures again, I'm hoping.
I find this very interesting, really. I guess that it seems to me that there hasn't really been quite enough stress in the news media that the severity of the pandemic is very largely due to the fact that there's zero immunity in the population to this, because it's a new disease of humans. Now, that I myself am very interested in biological invasions when animals and plants establish themselves in new territory. And for a disease, a new host is like a new territory. You might say that the switch of SARS-CoV-2 to humans from bats or wherever it was before, it's like an invasion. And really, it's just like what happened when Columbus and his crew disembarked from their ships in the West Indies and on the South American coast for the first time in 1492, and they exposed the original inhabitants of that continent to the very first time to smallpox and measles. And within 50 years, the population of that continent had been absolutely decimated because there was no immunity.
There's no immunity.
So, it's going to be tough until that immunity is there.
Yeah, so I guess that there was no chance of flattening the curve back in those days. So all we could do is this sort of, at the moment, we just have to rely on this sort of social immunity, as it's called, and try the basic sort of old-fashioned approach of just staying away from each other and minimizing that O in the dots, the opportunity for transmission.
Well, okay, I think that we covered quite a lot of ground this morning. Thanks a lot, Ed. I'll talk to you again about some other aspects of
Sure.
this. Thanks very much, and
Yes, sir.
see you next time.
Yeah.
Hope you stay well in
Yeah,
the
you too.
meantime.
Okay.
Yeah.
Cheers, Stuart.
Okay.
Bye-bye.
Bye.